Hello, my name is Damian Christian. I am the Strategic Alliances Specialist with the Men's Health Network. The Men's Health Network is a national nonprofit organization whose mission is to reach men, boys, and their families where they live, work, play, and pray with health awareness and disease prevention messages and tools, screenings, educational materials, advocacy opportunities, and patient navigation. We have spent many years working with the bipartisan Congressional Men's Health Caucus, co-chaired by Donald Payne Jr. from New Jersey and Mark Wayne Mullins from Oklahoma. We love their participation and their collaboration with this effort. Without them and their effort, this briefing and many others would not be possible. I also want to let you know, if either of the congressmen stops by, we're going to pause our briefing and let them speak for a few minutes, and then we'll continue. We are honored to have you in attendance today to this briefing on opioids and how it affects men in the workplace. As most of you know, this epidemic has had a ravaging effect on this country, but particularly men who are in working environments. We're going to have a full panel of speakers who are going to present unique insight and expertise into this very dire and very important subject. But first, our first speaker and presenter is Dr. John Bonhomme. Dr. John Bonhomme is on the board of directors for the Men's Health Network. He's the founder and president of the National Black Men's Health Network. He's a board-certified public health and general preventative doctor. From 2003 to the present, he has served as the corporate president and chairman of the Steering Committee for CHAMPS, which stands for Community Health and Men's Promotion Summit, providing free health screenings to economically disadvantaged minorities, of which he is an expert in this field. I would love to present and introduce Dr. John Bonhomme.
Good afternoon, everyone. Thank you for your interest in this topic. My presentation entitled Addiction as a Brain Disorder, it's a very important title because people have thought of drug use as being primarily a moral failing or something of that nature, but people have thought of drug use and addiction as primarily a moral sort of failing or a character disorder, but actually there are documentable changes in the brain that take place with drug use, and I think that understanding that will lead to development of better treatments and a better understanding of how to deal with this problem. First of all, let's do a little solid defining of what addiction is. Addiction is defined by compulsion. It's defined as continued substance use in the face of adverse consequences. For instance, a person drinks a pint of gin, gets into a wreck, gets their license taken away. 2 days later, they're back on the road drunk again. The punishment had no deterrent effect. The key into understanding addiction is that the person's function deteriorates, but the substance use continues. This is very different from a person, let's say, who has a ruptured disc in their back and they take a pain medication and now they can function. That's not addiction because their function improved when they took the medication. Deteriorating function, inability to function, continued use in the face of adverse consequences is what defines addiction. To understand addiction, you also have to understand something about tolerance. The brain becomes resistant to substances that are taken. So generally speaking, a lot of medications, especially pain medications, opioid pain medications, require an increasing dose with time. It may plateau at a certain level, but a dose that a person had that was relieving their pain may work for a while, but it may not work after months on the same medication. It might need increasing doses. Some people mistake that for addiction. They say this patient keeps asking for more and more medicine. Well, it may be that they've taken it, their body's become used to it, and it doesn't work as well anymore. So you may have to go up on the medication or use something different. Withdrawal is a feature of addiction. Basically, it's the set of negative mental and physical events that happen when a person who has been habituated to the use of a drug suddenly discontinues it. And what type of withdrawal you have depends on the nature of the drug. Opiate withdrawal may be characterized by sweating, vomiting, nausea, diarrhea, anxiety, things like that. Cocaine withdrawal might be characterized by severe depression, extreme hunger, desire to sleep. The nature of the drug defines the nature of the withdrawal. Surprisingly, withdrawal is not the whole story of addiction. You can have somebody who's been in prison for 5 years, let's say a heroin addict, and the day they get out, they start using again, and they're way past any physical withdrawal. They're no longer having the nausea, the sweating, or anything of that nature. There's something else going on that defines addiction, in addition to the withdrawal. There's also a phenomenon that we physicians have to be very careful of called pseudo-addiction. That's when a person behaves like an addict. They may go doctor shopping, they may buy medications off the street, but pseudo-addiction is caused when the pain treatment is not adequate to address the severity of the pain. A person may be driven even to illegal acts to obtain drugs and things of that nature, not because they are addicted, but because their pain is inadequately treated. And the distinction here is that if you manage the pain correctly, the drug-seeking behavior stops. You may have to use an additional thing, maybe a different medication, maybe a non-drug modality like epidural injections or something of that nature. But as soon as their pain is managed, they don't want the drug anymore. One thing that's important to consider in understanding addiction is route of administration, because when I started out with drug treatment, heroin addiction was synonymous with needle use, you know, the junkie with the tracks up and down their arms. But now we have so much opiates on the street. The heroin has become much purer. Now we have OxyContin, we have fentanyl, we have all types of Vicodin, all types of opiates on the street. The supply is so plentiful, people don't always feel compelled to use needles. That's a good thing for one reason, but the fact is that you're not going to spread as much disease as easily without people sharing dirty needles. But the bad part of it is that it's easier to induce people to try drugs when a needle's not involved. If you go to a party and you got a needle full of something, say, let's get high, and not too many people are going to take you up. But if you say, let's smoke it, or let's eat it, or let's snort it, more people will try that. And smoking is actually the most addictive pathway to take a drug, because if you snort a drug, not that much gets into your system because the nasal passages don't have that much surface area, and it takes a long time. It takes 30 to 120 seconds before you feel it. If you inject a drug in your arm, it'll go into the right side of the heart, out into the lungs, up into the left side of the heart, and then up into the brain. That takes about 18 seconds. If you smoke a drug, your lungs have a surface area that if they were unfolded, it would be the size of a tennis court.
Excuse me. I've just been informed that Congressman Mullen is here, so we're going to let him say a few words. First, just introducing. Sorry to interrupt.
No problem, sir. Say what you need to.
So Congressman Mullen is a congressman from Oklahoma. He has now been running his family business, Mullen Plumbing, since he dropped from the university. Hold on.
It's okay. You don't need to.
Okay, well, Congressman Mullen. Yes.
Thanks, Joey. Appreciate it. I don't have to bend down to the mic. I got to bend it down towards me. Hey, guys, first of all, thank you so much. I want to thank our panel and thank all of our guests for being here. When you start thinking about the workforce, as was alluded to earlier, I do have a plumbing company that employs about 200 people, plus I have a HVAC company, electrical company, trucking company, a construction company, an environmental company. I have 9 different companies. And the workforce is almost impossible to hire for. The biggest issue we have is actually people passing drug tests. And then those that can pass a drug test because they do have a prescription written for whatever injury they may have, because it is a construction industry, it's very difficult for them to be able to operate equipment, because my insurance company will say, well, they can, you know, legally they can work for you, but they can't work for you. They can't be out on a job site. And we've been treating more and more people, unfortunately, by prescription drugs. Now, I stand in front of you for a guy that's had 4 surgeries just this year. I have more metal on my body than what I can even begin to explain. When I go through TSA, we have a very close encounter. And I'm not kidding. I've had surgeries from my nose to my toes, and so I understand pain. I understand rehab. I understand the issue that we deal with. But the opioid epidemic is going beyond just the workforce. It's also entering into our families. It's busting our families up. And it's financially taking a strain. As a member of the Air Conditioning Contractors of America, as I said, we do have an HVAC company, it's one of the things that associations are dealing with constantly. A meeting I just walked out of was about trades and about individuals coming in and wanting to work. Once again, though, I go back to the whole thing is trying to get people to pass a drug test. 4 out of 5 heroin users now started because they were prescribed addictive opiates. And painkillers are quite different than most drugs that are out there. An individual that gets addicted to painkillers did it accidentally. Someone that's taken heroin or meth, they're taking a drug and they know what they're taking. They knew they were a drug addict. When someone gets prescribed 30 days of prescriptions medicine, and if you listen to most medical journals will even tell you that after about 3 days, that high intensity of drug to numb the pain isn't needed. And after about 7 to 10 days, your body becomes dependent on it. And yet we're prescribing them for 30 days, and they go back into the doctor, and the doctor asks them what their pain level is, and they say it's still high, but what they don't realize is they're actually experiencing withdrawals, not pain from the injury that took place. And now the individual accidentally became addicted to painkillers. And then the spiral effect takes place. And now it's having an effect on our economy. It's having an effect on our families. It's having an effect on us, or this room wouldn't be packed. This has touched my home multiple times. My wife and I raised my niece, who unfortunately had an issue in her family. A good friend of mine's father, who never drank, never was into drugs, went in for an elective surgery, got addicted to painkillers, and decided to end his life. I got a brother-in-law who is currently serving a 15-year stint in prison because at a young age he got addicted to painkillers that was left in a cabinet. Most of you in here probably have similar experiences. So what are we going to do about it? We're going to bring experts in. We're going to talk about it. We're going to continue to fight it. But ultimately, the responsibility starts here. Starts with me. Most of you guys in here have been prescribed pain medicine at some point, right? See, the difference is I choose not to take it because I've seen what it does. I know that I can set my jaw and make it through those 3 days. My wife says that I'm not normal. I explained to her that's true. Never claimed to be. But the idea, I know the fear that it faces too. I'm not willing to take the risk. Guys, I want to thank you for your patience to listen to me, but I also want to thank you for your passion to come and listen to those on this panel. And I want to thank the panel for taking your time. This is something that's vitally important to me, not from just a business perspective, which is having, as I said, a drastic effect. I kid you not. We could probably double the size that we are today, hire that many more people if we could get them back into the workforce. I'm no different than most people. Our biggest challenge is hiring people in the workforce. But more importantly, it's restoring that individual back into society to be productive like they were before they got addicted to the pain medicine. We do that by talking out loud about it. So thank you guys so much for your time. Thank you for giving me the time to be here. As you can tell, I'm very passionate about it. I'm always going to be involved in it. So if we can do anything for you, don't hesitate to reach out to us. Once again, thanks for letting us interrupt you too. I didn't want that to happen because you was on a roll, and I was remembering the commercials about this is your brain on drugs. I was seeing the egg hit the pan and start frying. Most of you guys probably don't remember that, but anyways, God bless you all. Thank you so much. Appreciate it.
Thank you so much, Congressman Mullen, for your work on this issue. We would like to continue with Dr. Brennan.
Okay. Again, smoking is actually the most addictive pathway because if a drug is smoked, it goes into the lungs, the left heart, and the brain, which takes only 7 seconds. Again, we said if you snort a drug, 30 to 120 seconds to get an effect and a low blood level. If you shoot a drug, 18 seconds because it has to go through the right heart, the lungs, and then the left heart to the brain. But if you smoke it, 7 seconds. Now, if you were training a dog with food rewards, which would be most effective? If you give the food in 7 seconds, in 18 seconds, or in 120 seconds. The faster the consequence, the greater the effect on learning in the brain. And the other problem is that smoking is socially acceptable. Anytime that I hear a drug of any type become smokable, I'm very concerned because more people will try it, and it actually leads to addiction very quickly. That's why it's so hard to stop tobacco. Okay. How does the brain work? Okay, this is a picture of a synapse, 2 nerve cells talking to each other. What happens is that the one called the axon dumps chemicals on the dendrite, which is the receptor, and then they're pumped back into the axon. That's the way that nerve cells communicate with each other. They communicate chemically. And to understand addiction, you have to understand something about this process. Neurotransmitters are the chemicals that they use, and they go across synaptic gaps. The way the drugs work is that they modify the effect of neurotransmitters. They may increase them, decrease them, block them, mimic them, or modify them in other ways. Some of the neurotransmitter functions, no need to know all these, but I want you to focus on dopamine, norepinephrine in particular. Those are the things that they do. Acetylcholine is associated with thought and movement. A lot of the drugs that they use to treat Alzheimer's, Aricept and Namenda, they work on acetylcholine. Dopamine has to do with pleasure and motion. When people have Parkinson's disease, their bodies are very stiff. That's the dopamine system. But also, dopamine is involved with pleasure. Serotonin, the serotonin reuptake inhibitors like Prozac, the antidepressants, they work through serotonin. Norepinephrine is your alertness, your call to action. That's important with opioids. Glutamate is the brain's accelerator pedal. Gamma-aminobutyric acid, or GABA for short, is the brake pedal. And endorphins and enkephalins, the dynorphins, are the brain's natural painkillers. Your brain makes substances like opioids, or opioids are like the substances that your brain makes, depending on what order you want to put it in. But that's the mechanism of opioids. Okay. The way that addiction works is that by altering neurotransmitters' functions, they hijack the brain's reward system. They take over the same processes that govern our natural drives for food, water, sex. They get taken over. Addicts can reach a point where they no longer derive pleasure from natural means anymore. They may be able to enjoy only the drug, or they may not even enjoy the drug. They may have to use it just to feel normal. They can get that extreme. A heroin addict told me, when you get real strung out, you're not shooting to get high, you're shooting to keep straight, just to feel normal. Opioids have actions, excuse me, like morphine. They're natural opioids that are found in the opium poppy, morphine, codeine, thebaine. They are synthetically altered derivatives of the natural opiates. Hydromorphone is dilaudid, hydrocodone, oxycodone, oxymorphone. Heroin is diacetylmorphine. It's just modified morphine. It gets into the brain more quickly. There are synthetic opioids: fentanyl, methadone, tramadol, propoxyphene. Fentanyl scares me the most because that can be made in illicit labs, and it's much, much more powerful than morphine. I think fentanyl is something like 80 to 100 times more powerful than morphine, and some of its analogs are even stronger than that. So when you hear some of the opioid deaths that we've been seeing, it's been somebody sold heroin, but it actually contained fentanyl, and even seasoned drug addicts can die from shooting that or from using that. Sometimes they're making pills that look like OxyContin, but they're actually fentanyl, and it's much too strong. This is a very dangerous drug, and it doesn't need to be imported. They can make it. Okay. To understand how opiates work, look at the diagram, endorphin. That's our natural brain painkiller. Look at the area in the rectangle, and look at the area in morphine. You see how the brain can mistake one for the other? You know, they look so much alike. They look so much alike, and they work on the same receptor. They're hardly different chemically. So the basic issue is that opioids are basically chemical imposters that act like the endorphins, like our natural painkillers. Overdose occurs when the person takes a dose with the physical condition that they can't handle it. A lot of the time, it's a drug interaction. The class of drugs, benzodiazepines like Xanax, Valium, those drugs are very dangerous to mix with opioids because they both suppress respiration. And when you put them together, a person might be able to handle a dose of one or a dose of the other. You put them together, it can prove fatal. Alcohol can also be fatal when mixed with opiates. Sometimes a person has a health condition like chronic lung disease. They have trouble breathing in the first place, and you give them an opiate, and opiates suppress breathing. They can't handle as much as a healthy person would. And so when overdose, the person can't be awakened, pupils can become small, skin becomes moist, bluish in color, breathing slows down, and death may occur, usually because of respiratory depression, meaning that they're not breathing anymore. Okay, we're going to get into some neuroanatomy. Don't worry about these names. They're not all that scary, but it's just to let you know what's happening when a person takes an opiate. The area is the ventral tegmental area, just the VTA for short, and the nucleus accumbens, or NA for short. When a person takes opioids, opioid stimulation of the VTA causes it to release dopamine, the pleasure chemical, in the nucleus accumbens. And then the person may get a euphoric recall that leads to the drug craving. But then what happens with repeated exposure, the brain becomes resistant. So you need increasing doses of opioids to get the same effect. The tolerance occurs because the brain cells become less sensitive, so you need to take more and more to release that. Then it becomes without the opioids, the brain doesn't release enough dopamine, and the person can't enjoy normal activities. The fancy psychiatric word is anhedonia, that they can't feel pleasure anymore without the opiate. So when a person becomes too habituated to the use of opioids, they can't enjoy normal activities. The locus ceruleus, now that's a fancy name. Locus means spot, and ceruleus means blue. So locus ceruleus just means the blue spot. That's an area in the brain that releases noradrenaline. Noradrenaline causes your alertness and your breathing. When you see a person who's high on opiates, you see that their alertness is down, they may be nodding and stuff like that. They're not getting enough adrenaline activity, and their breathing slows down. But then with repeated exposure, the locus ceruleus becomes resistant to the opioid too. It increases its output of noradrenaline. So then now when you don't have the opiate, the person has jitters. They're jittery because they got too much adrenaline activity in their brain. They're having anxiety, they're having muscle cramps, they're having the withdrawal syndrome. If you took a needle, an electrode, and put it in the locus ceruleus of a person who never used opiates, and you stimulate it electrically, they'll have the opioid withdrawal syndrome. They'll be sweating, their nerves will be jangling, they'll be vomiting, they'll have diarrhea and things like that. So what basically happens is that with addiction is that as the brain gets used to the drugs, the brain reaches a point where it needs the drugs just to get back to normal. It's not releasing enough dopamine, so they can't feel good. It's releasing too much adrenaline, so they're feeling jittery and anxious. And that's the reason why addicts seem so crazy. You know, why would you use a dirty needle knowing that you might get HIV or hepatitis or something of that nature? Because they're driven to. They can't feel good. They feel terrible. You look at a person in an opiate withdrawal, you say, it looks like a bad case of the flu. Actually, it feels a lot worse than that. So this model, the basic idea, these researchers said that there's a basic biological setting of the way that your brain works. It releases a certain amount of dopamine so you can feel normal. It releases a certain amount of noradrenaline so that you can be alert and so that you can breathe normally. But what happens when the person takes opioids for a prolonged period of time, their brain doesn't release enough dopamine without the opiate, and it releases too much adrenaline without the opiate. So then the person needs the opiate. That's when the addiction actually occurs. The set points of the brain change. Now, the congressman was dead right when he said, you know, don't take opiates for that long. Last year, I had my first time I had a tooth extracted. It was a wisdom tooth. They gave me 20 OxyContins. I took 3 of them. I won't stay on that stuff more than a few days. I just won't, because I've seen too many people get on it and can't get off. So by changing the set points of the brain so that the opiate is required to maintain normal levels of dopamine and noradrenaline, that's the reason why the person is addicted. So addiction needs to be regarded as a brain disease, not a moral failing. Now, when people are put on opiates, if they're taken off gradually, a little bit at a time, a lot of them can get back to normal if they haven't used too much for too long. If a person's been using opiates for a year, and I'll tell them, you know, we'll take 6 months and we'll gradually get you off, give you a methadone dose or buprenorphine, and slowly bring you off. A lot of people can get off. When they've been using 10 or 20 years, it's a lot more iffy. If they have a chronic pain problem, then it's much more difficult because they have to face the pain in addition to the withdrawal. And that's where it connects with the workplace. When we talked about men in the workplace, 93% of workplace deaths are men. And those deaths represent only a tiny fraction of the injuries. So I spoke to a man who was a laborer all his life. He asked why his hand hurt him so much. You could have struck a match in it. You know, they have arthritis, they have all kind of problems, they have back injuries. A lot of the patients that I've seen, I was amazed when I went into methadone treatment that a lot of the people that were coming there, they didn't get addicted because they went to parties and got high. They got addicted because they got hurt on the job. One guy fell 50 feet onto concrete and smashed half his body. You know, some people were in car accidents. Some people had a cancerous tumor removed and they were in chronic pain. You know, the fact is that a lot of people who become addicted to these drugs are not people who are trying to use illicit drugs, at least not initially. They just got hurt. So the pain management, doctors need to be more educated about how to use these drugs short term and how to taper them, you know, to get people off. Don't put a person on opiates for 6 months and then suddenly cut them off. They'll be climbing the walls because their brains have readjusted to too little dopamine and too much adrenaline. That'll make them really miserable because the set point has changed. Cocaine also acts by, I know the time is getting short, so I'm going to run through these. Cocaine also works through dopamine. All drugs of addiction appear to work through the dopamine pathway, the reward pathway of the brain. So cocaine works by blocking the reuptake pumps, so the dopamine that's released to the other cell doesn't go back. It just stays there, but then eventually becomes depleted, and the person gets depressed because they can't feel good. Amphetamines, pretty much the same thing. Amphetamines worry me because the chemical structure is so simple, you know, that can be made from chemicals that don't need to be imported. Amphetamines, ecstasy, cocaine, they're all stimulants, cause the same basic problems. Depression, sleep problems, drug craving, paranoia, can cause psychosis, muscle tension, heart rate and blood pressure increases, brain damage. When they put people on methamphetamine, for 2 weeks, it took 6 months for their brain scans to start to come back to normal and 2 years for them to recover fully. So these drugs can quickly cause changes in the brain that lead to addiction. Marijuana, I bring that up because it's probably the most common drug, illicit drug that's illicit in most parts of the country, but it does have medical uses. Personally, I'm a little leery about legalizing its recreational use because I'm worried about driving under the influence. You know, it's a lot harder to detect marijuana. If you take some marijuana and some alcohol, they're synergistic, so your blood level of alcohol may not be over the legal limit, but you may still be impaired. Okay, the self-medication hypothesis. Some people believe that people are predisposed to addiction because they have emotional, physical disorders. The drug of choice may be related to what the underlying disorder is. Like, for instance, people who have anxiety, they tend to like the downers. They like the alcohol, they like the heroin, they like the Xanax because it calms them down. People with depression tend to like the stimulants, like the cocaine and the amphetamine, because if they got low energy, they get a big blast of energy. It's only brief, but they feel, you know, energized and that type of thing. So the underlying psychiatric problem can predispose to drug use and subsequent addiction. Medications for opioid treatment. Methadone stimulates the opioid receptors. Naltrexone blocks the receptors. Buprenorphine is both an agonist and an antagonist. There's political opposition sometimes to using drugs like methadone because they say, well, methadone is an opiate. If you give that to a heroin addict, isn't that like giving gin to an alcoholic? And my response is, a turtle and a cheetah are both four-legged animals. Do they behave alike? You know, the point is that methadone is very slow. It gets in your system slowly so you don't get high. It comes out slowly so you don't get withdrawal. So the point is that methadone, yes, it's an opiate, but it doesn't behave like the opiates of abuse. So that's the difference between them. The way methadone was discovered was that when they were trying in the 1960s to help heroin addicts, they tried all kinds of drugs and they couldn't help them. And when they tried the methadone, one of the patients told a psychiatrist, Dr. Marie Niswander, I used to like to paint and I'm thinking of getting back to it. And she was shocked because she never heard them talk about anything but drugs. And they were showing outside interest. And they realized that the methadone kept them not high and not in withdrawal. When it was dosed properly, it kept them at an even keel. So that's the reason why it worked. Now, some people can come off of methadone gradually, but no, the drugs like methadone and buprenorphine, they're not like the opiates of abuse. They're long-lasting, and they don't promote abuse the way that those do, the others do. We need to be mindful of dual diagnosis, that a person can use drugs because of an underlying psychiatric problem. According to the American Medical Association, JAMA, 37% of alcohol abusers and 53% of drug abusers have at least one serious mental illness. Sometimes you have to treat both. You have to say, is this person using drugs because they have depression, because they're schizophrenic, because something else is going on with them? You have to look at that as well as just the drug problem. I'm bringing this up, I'm going to run through it briefly, only because I want people to be mindful, as I learned and in my work as an addiction physician, that addiction doesn't just come by itself. It comes with other diseases. HIV, needle use can cause HIV to spread explosively. In the Ukraine, there were no HIV cases among injection drug users in 1994, but 31 to 57% were HIV positive about 2 years later. So drug use, needle sharing, because it's a direct blood-to-blood communication, can cause HIV to spread explosively. Hepatitis C, most of that was transmitted by needles in the 1960s and 1970s, and that can lead to cirrhosis of the liver. And I had a patient like this next lady, liver cancer. And that's not pretty, I know, but that's what hepatitis C can cause. Tuberculosis has been increasing because of alcoholism and also because of HIV. HIV-positive people are very sensitive to tuberculosis. There are local needle effects, abscess, cellulitis, which is infection of the tissues, phlebitis, which is infection of the vein, endocarditis, which is lining of the heart. The Mexican mud heroin is very dirty, and it can cause disease even with sterile injecting equipment, and it can even cause botulism. Sexually transmitted disease, they tested 407 subjects in a drug treatment program. 62% had markers for sexually transmitted disease. So in drug treatment, we have to institute HIV and STD screening and treatment. And I think that's about it. I had to run through some things, but I hope that was informative. And if there are any questions, is there time for questions?
We're going to save questions for the end.
Okay,
so.
great.
Thank you. Our next panelist is Todd Washing. He spent 10 years on Capitol Hill, and now he works as the Director of Industry Relations for the Air Conditioning Contractors of America.
Thank you. Like Damien said, my name's Todd. I work for the Air Conditioning Contractors of America. We have about 4,000 members across the U.S., and we're the national trade association representing the guys and ladies that come into your house and fix your air conditioning system. We're glad to be here today and appreciate Mr. Mullins stopping by, and he's a distinguished member of our association. We're always excited to see him. When ACCA, that's Mr. Mullins' truck, so. When ACCA partnered with the Men's Health Network, the opioid crisis wasn't really what we had in mind. We wanted to talk to men and get them thinking about healthy minds and bodies, which is generally not what they're concerned about when they're running install crews, service calls in the 90-degree summers. That's what they're most concerned about. And the fast pace of their work, coupled with the physically demanding nature of crawling through crawl spaces, pulling boilers and furnaces up and down stairs, and pulling compressors out of equipment, that leads itself to workplace injuries. And it wasn't until our board of directors met with their senators and representatives that the opioid crisis really came to my attention and how it was impacting contractors. One of our members from North Carolina was talking to a senator, and he said the biggest problem he was having finding employees was getting them to pass drug tests because the opioid crisis was so big in his area. And then he relayed a story about how he had an employee who was being rushed, and that person subsequently was injured and was prescribed painkillers. He became addicted, and this contractor lost this otherwise good employee. So he went about figuring out how to address this problem in the workplace, and ACCA had to step up and start talking to our contractors about this issue since we figured out it was really becoming a national issue for our members. So what we did, and you can't read all of this, but we started talking to the Men's Health Network about some of the physical signs that contractors need to be aware of when they have employees who they suspect may be on opioids or addicted to them. And some of the physical signs we tell them to be aware of are drowsiness, dramatic changes in their moods, abnormal fatigue and heavy sweating, some of the issues that Dr. Bonham was talking about. And we also tell them to be aware of people who are talking about financial problems and asking coworkers unusual questions about their doctors. So that's some of what we do at the trade association level to just get people talking about the issue, which is really one of the biggest problems. And for a more robust plan, we partner with Federated Insurance. They're a national corporate partner of ACCA, and their representative, Nate Oland, is here today. They provide us with a lot of information that we can send to our members, but they also provide their members who are signed up with Federated robust risk management plans that we think contractors should implement in their business. And their 6-step risk management plan starts with a written policy about drug abuse. Contractors should have a clear, enforceable written policy that includes the purpose of the program, the expectations for employees to comply with it, and the options offered for assistance if an employee thinks they may be having a problem with these issues. Step 2 should be a robust communications and training program. Communications is so important because people are scared to talk about the issue, and they need to be open about it, especially the employers. They need to set the tone in their business. And the training, they need to train people on how to spot possible signs of addiction and abuse for their coworkers. Step 3 should be enhanced training for supervisors. Supervisors need to take in to account the unique characteristics of where companies are located, because some contracting businesses are going to be more prone to opioid addictions. Look through West Virginia, North Carolina, Ohio. That's where we're seeing a lot of our contractors having problems with this issue. And the supervisors need to go through additional training to know how to manage their employees and spot, be more heavily trained on how to spot signs of addiction. Step 4 that Federated Insurance recommends is to document and keep routine documentation on employees who have completed the drug training program, and reinforce through routine communications, maybe in their paycheck stubs or hang infographics over the coffee machine, the benefits of a drug-free workplace and what employees can do to help their coworkers if they suspect something is going on. Federated also provides drug testing for contractors, and this is something that is required in some states, and we really push contractors to make sure this is a program that they have. I believe Federated offers it for free for your clients, so it's a resource that's out there. And the final step in Federated's risk management plan is to have an effective employee assistance program. An effective program creates a positive atmosphere for employees and promotes a higher quality of life for everyone. Some states actually require you to have an employee assistance program if you have an employee who tested positive for drugs. And we tell contractors that they should talk to their federated representative, or if they have another insurance company, talk to that representative, but also go to SAMHSA's website. They have about a dozen different programs that contractors can sign up for to send their employees to. And in close coordination with a good risk management plan is some of the best practices we've learned from HVAC contractors. We have a member in the DC area who has had an employee injured, and he understands that the opioid issue and addiction is such a problem that what he did was he brought his injured employee back to work, put him on modified duties, because he said that's going to be the best thing that he can do as an employer to get his technician, on a regular schedule, not sitting at home constantly thinking about the pain that they're in. So that's something that we really tell our members to do. It's going to cost them a little more money because they're going to have to pay that person their normal salary, but it's going to be a lot better for the entire company. The member we were talking to said this employee said it was the best thing that his boss could have done for him. So we're really proud of that. And that's really all we have for the air conditioning contractors. I can answer some more general questions and always talk to you about HVAC issues if you want to. Thanks for having me here.
Thank you so much, Todd. And our next panelist is Dwayne Pearson. Dwayne Pearson is currently with Premier Inc., and he is here to give his very unique insight on this issue. Thank you.
Thank you. Thank you for having me here today to talk on this issue. So Premier is a collaborative of 3,900 hospitals nationwide. So our members come together to improve healthcare outcomes, change the way we're delivering healthcare, and how we pay for healthcare in the future, in the sense through that care coordination and improving quality outcomes. One of the biggest issues for us and how we got really into this effort of how we address the opioid crisis is Premier has a large accountable care organization, collaborative, so otherwise known as ACOs. So ACOs are networks of hospitals, physician groups, and others who take on the risk of taking care of the patient population in their communities. And so they enter into agreements with Medicare or Medicaid in order to basically have an opportunity to take less upfront on the reimbursements for opportunity to possibly engage in shared savings with Medicare or Medicaid at the end by helping improve outcomes and cost savings for the government. What we found is that in 2013, we actually had our ACO, we got our first information, which is when we enter into it, we got claims data to understand the issue. And as we worked through this issue over the years, we're discovering more and more that we weren't getting any information on the sense of how to help those suffering from addiction. And so as we dug into this issue, we were going through the process, which became a very complicated issue, is that there are two privacy laws that govern healthcare in this country. One, probably everyone in the room will probably recognize, is HIPAA. HIPAA is the gold standard, passed in 1996. It covers every disease and condition with the exception of addiction. So alcohol and drug addiction aren't covered by HIPAA. So for providers in the healthcare community, whether you have HIV/AIDS, STDs, Hep C, cancer, to diabetes, or whatever your condition is, we can coordinate and share the medical record in order to do the full care continuum and treat the patient as a whole. When it comes to addiction, the challenge lies with a law known as 42 CFR Part 2. It was passed in 1972. The reason for the law was, at the time, it was at the beginning of the war on drugs. In some cases, certain methadone clinics were being raided, and the paper medical records, which were at the time paper medical records, most people are moving to electronic health records today, were being seized and used in criminal prosecution. So the law that went into place with 42 CFR Part 2 is 373 words long. And what it does is it protects the patient from criminal prosecution, allows them to seek treatment in a safe process, but it also puts them in control of their medical record, in which they have to get consent for a physician or a hospital to see their medical record. Flash forward to 1996, we passed HIPAA. We're allowed to share medical records for everyone. And today, we still have that law part 2, and the challenge we're having as we move into the 21st, as we're in the 21st century and we move forward in healthcare delivery is the patients as they present in emergency departments, we don't have a full capable understanding of their conditions because the challenge really is that the electronic health record doesn't capture the addiction record. And most addiction providers, you know, they keep it, they're going to be keeping a paper record. So as we deal with this population and the challenges we have with it is that as the doctor had mentioned, there's a lot of complications with buprenorphine and there's a lot of contraindications in the sense of what drugs might contraindicate with it. And as we try to help people get off of whether it be prescription opioids or heroin and other items, we have to be very mindful of patient safety and care coordination, and those aren't possible now if we can't see the full medical record. And so we've been working with Mr. Mullen and Mr. Blumenauer on a bill to align Part 2 with HIPAA so we can share the medical records. And so you might think, well, what does that do for the workforce? What does it do for health? Well, if you look at it, if we're not coordinating care, if we're not able to do the warm handoffs for the emergency department, we can't get people to community services. If people can't get into community services or the treatment areas, they're not going to get the help they fully need. And it makes it harder to treat them back home. It makes it harder for the providers when they see that one individual who's a frequent flyer of the emergency department coming up to 15 to 20 times for an addiction or for overdoses. And it's really putting a burden on the system to where in which, how do we help these patients? So we've been advocating to align Part 2 with HIPAA, the HR 5795, which is moving to the House floor, and we thank Mr. Mullen and Mr. Blumenauer for their support on this. But it really is playing a part in the sense of how do we do care coordination down the road if we don't change this. We can't do telemedicine safely if the provider who could be 200 miles away from the patient can't see the full medical record. And what if that patient doesn't have a hospital near them? They don't have an emergency department near them if they have an adverse event. How do we prevent, you know, that issue? How do we do, you know, medication reconciliation safely if we can't see the full medical record? And, you know, how do we change the way we do health care and make sure, you know, as we change the way we pay for health care, if the provider can't really understand the patient and to help them in that, would help the government really and others in the sense of getting costs down and better outcomes. So those are some of the big conditions from Premier and the healthcare community's aspect is we need to make some changes to an old law that'll help us to do care coordination and improve patient safety. I'm happy to answer some questions a little bit later.
Thank you so much, Dwayne. Our final panelist is Andrew Sperling. He serves as the Director of Legislative and Policy Advocacy at the National Alliance for Mental Illness, and he has served in this role since 1996.
You don't have to read all that.
So, thank you so much, Andrew.
Yeah, because in 1996, I've been up here a long time, and I'm a former congressional staffer as well. So first of all, I want to come, you know, follow up on Dr. Bonham said. What's encouraging about what's going on right now in Congress this year is we're really, not for the first time, but certainly for the most sustained effort, we're actually dealing with addiction as a public health issue. And it took a long time to get there. We're not going to arrest and incarcerate our way out of this problem. And I think that's become a bipartisan universal principle that's driving all the opioid legislation that's moving forward in the Congress this year. So that's very, very encouraging. Mental health and substance use disorders have always been sort of second-class citizens in the healthcare system. I've experienced this for a long time. I first started working on mental health parity legislation in the 1990s. And way back when we did that, it was actually a struggle to actually get substance abuse into these insurance parity bills, where we were going to put requirements, not a mandate, but a coverage condition that if you cover mental health and substance use disorders, you're going to do it on the same terms as conditions as medical surgical coverage. That bill actually passed the Congress, a very small version in 1996, that actually didn't include substance abuse. It got excluded. And the prevailing attitude in a lot of members of Congress at the time was, hey, addict, you did this to yourself. No one strapped you down and started pouring vodka down your throat or forced you to take these opioids, so we're going to exclude, it's not going to be a part of this insurance parity. Well, we made huge advances in 2008 with the support, mind you, of the employer community. Todd, you'll recall at the time the Chamber of Commerce and the National Retail Federation, large employee organizations, negotiated painstakingly that parity legislation, and we're behind it and wanted to do it. Employers and health plans realize we can't do this anymore. We've got to cover mental health and substance abuse on the same terms and conditions in health insurance plans. That passed in 2008. Now here we are a decade later, and this is another parity bill. It is Congressman Mullen, Congressman Blumenauer's legislation that Dwayne talked about. We're now going to have mental health and substance abuse records treated the same as diabetes, heart disease, and everything else in the healthcare system. Why is this so important? Why is this bill so important? And I should note parenthetically here, the second week of June, those of you who are House staffers, is going to be opioid week in the House of Representatives. Speaker Ryan, this is going to be a big package. It likely may very well be separate bills where the House, your bosses are going to be voting on possibly as many as 100, 140, 150 different opioid bills. I would argue that the most important of these bills is going to be H.R. 5795, which was reported on a bipartisan basis last week by the Energy and Commerce Committee. We had 7 Democrats support the bill, so we've got real bipartisan support behind Congressman Mullen's bill to finally read parity to the sharing of medical information and make sure that behavioral health records are not kept separate out of the main record. And this is a huge step forward. We have to be able to integrate care. And I think Dr. Bonheim touched on this. We're not going to be able to treat serious chronic conditions in this country like diabetes, heart disease, unless we're also integrating behavioral health into this. Because oftentimes people, the steps that Dr. Bonheim talked about, somehow people can get addicted, it's for an underlying health condition. Whether it's an orthopedic condition like a bad back or major surgery that an individual has to have, and they end up being addicted. And unless you deal with that integration, you're not really going to make progress. So I'm encouraged by what's happening, but we've got a long way to go. And we really appreciate the engagement of employers on this. They have a huge stake in this. Thank you.
Now the floor is open for questions. Okay, well, I would love to thank the panelists for coming here and speaking with us, so please give them a round of applause. And if your boss doesn't want to join the Men's Health Caucus, you can contact Taylor Hiddle from Congressman Mullen's office or Stephen Schultz from Congressman Payne's office. So in conclusion, since there is no further questions, I would like to thank you on behalf of the Men's Health Network and the Congressional Men's Health Caucus. Yes?
I have a question. I wanted to ask, have you found with the addiction problems in the heating and air conditioning industry, have you found a lot of them to be caused by work-related injuries?
It's both. I mean, one of the problems is finding people to work for you who can pass the drug test. But if workplace injuries, while we try to prevent them, that is another problem with it. Yeah, so it's both.
Because as I said before, I was shocked by the number of people who I had to treat for addiction who never smoked a cigarette before they got hurt, you know.
Well, any other questions? Okay. Well, thank you so much for coming, and we'd like all of you to have a good day. Bye.